Thank you, sir. Raghuraman, sir. We have been friends since long and we have seen each other in conferences. So I am blessed that you are chairing the session on Sunday, right from Ahmedabad. So we
It's a
will,
learning session,
yeah,
so I think we'll learn and get
and
better.
only four speakers are learning here. So, so let's go ahead because we need to abide by the time. So, without wasting time, and it's a great show by our showman, Dr. Bansi. At outset, I'm thankful and blessed that I always be a part of Diabetes India. Continuous glucose monitoring means using a device to automatically estimate your blood sugar. So you can see what the blood sugar graphs are going on, the trends, spots, and everything. A CGM has three parts. We all know, and it's nothing new about that. A disposable sensor, a implantable sensor, or a transmitter. And this works in a toto to give us what is the things going on in our interstitial tissue. So, triangle of diabetes care, a concept bringing together the need to improve the following in the management of diabetes because HbA1c is not at all taken as a only one matrix. It can give a criteria that what your sugar levels are going for last 3 months, but probably the glycemic variability is coming up with a great concept. So, a common cause for hospital admission to minimize hypoglycemia, better manage the overall glucose level, and reduce limiting glucose variability. So that's why we need to check what is going on inside and what minute to minute matters inside our blood vessels. So you can see here a graph where the HbA1c of the both the graphs are same. A1c is 7.7 in graph A and A1c is again 7.7 in graph A. But when you see the glycemic variability, the mean excursion and the different matrix which can be displayed with the CGM, you can very well see that in second graph you have a high degree of variability. So this same HbA1c can be depicting a false understanding that I am in a total control or I am in a better control. When my HbA1c was last time 9 and now 7.7, but my glycemic variability is not good, then probably this HbA1c, which is 7.7, is not at all equally than a 7.7 of graph 1. So international consensus on time in range is published way back in June 2019, and it provides more information to the AGP graph by showing the percentage of readings and timing per day in and out of range. So it helps to provide an actionable insights on daily basis. What are the international consensus that clears? They say in type 1 and type 2 diabetes, you should have more than 17 hours per day of time in range. Means 70% of the time of your body should have a glycemic variability less than that. So 70% of the time when you are having 17 hours in 24 hours, when you have uh, good control, then probably you're going to have a very, very good HbA1c that will be same HbA1c which could call be good HbA1c. So less than 4% should be time below range and time above range should be less than 25%. So time in range is an actionable measure that reflects acute glycemic control and can be quickly assessed with the three parts, which is time in range, time below range, and time above range. And these things to be taken in care that we usually say that 70 to 180 is the best sugar level in the body. So that has been developed 25% to 75% of percentile of your time in range comes to be taken as a target measure. So data interpretation, what is the trend, what is the pattern analysis? You need to have top 10 values insights like assessing, determining, quantifying, verifying, measuring. And that's the way you can properly decide the insulin dose. If the patient is in insulin, there should be a correction factor according to insulin sensitivity. If you're very well versed in reading these graphs, you can do that and uncovering the patterns of hypoglycemia, evaluating, titrating, discovering, revealing. So clinical guidelines for use of time in range, they say that the all guidelines by ADA, AC, AD, ESD, FEND, and SPART, they used to recommend every patient should be subjected at least once in a year for this kind of devices to get better insight about what is going inside. And a tool becomes better tool when it is indicated for a personal use. So that's why I say that what topic given to me is lifestyle modification as a platform using TIR and glycemic variability. So common issues with CGM: cost, insurance coverage, may require calibration, need to remember to scan, can be complicated to learn, alarm fatigue, constant pressure on the sense of the sensor, skin irritation. But there is a big but, that lifestyle modification program, this was the topic given to me, is tips to improve glucose control using CGM. The only motivation when we are in diabetic, what is going inside the body when I am taking breakfast, lunch, or dinner? Nothing is like a robotic system in our body. We are emotional molecule. We do have certain excursion in our body. So you need to wear CGMs as much as possible. Know your personal glucose target. Explore the big bad world of food. Test what really harms and helps your glucose control. Food charting, food gimmicks, smart eating. So don't waste your data and prioritize in emphasizing its use in body composition analysis. We have one machine also either displayed in our arena, that is body composition analysis, that reports of body composition analysis with CGM can be in latest future AI device that which can endeavor our gym and weight training and our food habits. So Dr. Parimal has given one AI-based diet chart also. So we can incorporate all these things and we can use them smartly when we use as a TIR as a time lifestyle modification tool. So indications for use: HbA1c that does not match SMBG, elevated HbA1c, hypoglycemic pattern, high glucose variability, insulin adjustment, non-compliant patients, hyperglycemia patterns which are not explained by normal routine, therapy adjustment, and baseline assessment. So roadmap to leverage AGP plus TI for diabetes management. Suppose a patient present at clinic, screen for underlying problem, check historical blood pressure reports, blood sugar reports, identify indication of CGM, patient consultation in the clinic, then rational use of CGM to confirm underlying problem because every patient is a different patient. Diet lifestyle advice according to the glycemic variability of the patient. If a patient has high degree of excursion at lunch level, you need to give that kind of readings to that patient to take highest possible dose at that time rather than having a breakfast or dinner time. So you can very well see what you are going to do and that gives the results. So importance of TIR and diabetes outcome: an increase in TIR of 10% or 2.4 hours per corresponds to almost 0.6% decrease in HbA1c, and this increased TIR improves treatment satisfaction in patients. The huge cost saving can be done. There are newer CGM technologies, wearable bead, sugar bead, which is a non-invasive sugar, method, which can sit on your skin surface and take sugar without pricking needle. Newer CGM technologies, implantables are coming in future. There are ketone devices coming, which can give glucose and ketone at the same time. Future directions is very rosy, and CGM accuracy will give in automatic insulin delivery. So because I end always with a poem, so life is a balancing act and balancing act of life. Life is a tightrope. I walk the thin line, a delicate dance between work and play, a precarious prance. One misstep and I tumble to ground, yet with each step forward, balance is found. Like a juggler, I keep multiple balls in air, family, friends, and passion all compare. Each one a treasure deserving of my care, yet if I drop one, the others may impair. So I'll keep walking this tightrope of life. With each step forward, I find my balance and thrive. Thank you. Here also a balancing act.